Good morning, everyone. Thank you very much for joining our webinar on comfort from diagnosis to end of life, specialist seating for people with MND this morning. Very good to have you on board. I know it's school holidays, so we've probably got a few less attendees than usual, but we're still over 550 signed up, I believe. So we've got a lot to go through today. We've got Joe McConnell back with us, who I'll introduce in a moment. Just a little bit about Vivid Care before we start, for those that haven't met us before. So we're a family-run business and we really specialise in seating and posture, particularly in care chairs and specialist rise recline chairs, all of which we make in the UK. And we've got chairs all over the world now and in over 80% of NHS hospital trusts, but we do a lot of on-site assessments with therapists and healthcare professionals too. And we deal with private individuals. So a lot of different markets, but really we focus on each individual. We're very keen to get the right posture, the right comfort, the right support for each person, because we all know how much that can affect people's lives. And that's really our mission, to enhance quality of life. And I'm sure that resonates with everyone on the call here today. It's all about improving quality of life. We've got a wide range of chairs, but our flagship range is the Lento chair range, which you may have heard of. There's a number of different models within the range, and they're all very adjustable. We will be going through some of them that are specifically good for MND later in the call. There'll be a live demonstration, so I'll go through some of the models in a bit more detail later. But at the core of everything we do, including development of our Lento range, is this one word, and that's comfort. And I think this is something as therapists, as clinicians, as people that are dealing with patients, I'm not sure we always think about this as much as perhaps we should do, because we get distracted on things that are rightly important, like pressure care or posture, etc. But really, all of those should lead towards comfort, because if we aren't looking for comfort, then we've lost sight of that individual. And comfort, all those things lead into comfort, and comfort is what encourages someone to get out of bed into a chair. It's what encourages people to get moving, prevent further deconditioning, get them up and about, and ultimately improve their life, improve their social interaction, and improve their bodily functions, and the list goes on. So comfort is really key, and I think that's something that we really focus on. And then lastly, just before I move on to Joe, we do have a website address there and some contact details. There are loads of resources on the website, loads of articles, loads of downloads, loads of past webinars. Please do have a look. And it also obviously goes through the chair range there too. And if you do want any kind of demonstration or assessment for any particular client, please do contact us. We offer no obligation assessments, and it's something that we're very used to doing. We've been doing specialist seating for over 30 years. So we love a complex case, and we love to get hands-on and to work with yourselves to get the right outcome for each client. Little note about how this webinar will run. So I'm going to hand over to Joe in a moment, and Joe's got loads of information to go through, specifically about MND and seating for MND and what to look for. And then I'll go downstairs into the demonstration room and spend about 5 minutes going through some of the chairs, kind of bringing what Joe's said to life a bit more, and showing you adjustments on the chairs, what to look for on different chairs, etc. With regards to MND. Following that, we'll have a live Q&A section. And so please, as we go through this webinar, if you've got any questions at all, please do pop them on the Q&A section. You'll see a button at the top of the Teams screen. Just hit that, pop your question in there, and we'll do our best to answer it at the end of the webinar. Now, I know there'll be one question which everyone will want the answer for, and I'll give you the answer now. A lot of people ask us at the beginning of these sessions, will I get the slides afterwards? Will I get the recording afterwards? Yes, you will. Everyone that's registered, we've got your email address, and I'll be emailing you out afterwards with a copy of the slides and a link to the recording once it's uploaded to YouTube. But any other questions, please do pop them on the Q&A section there. We've actually deliberately disabled the chat function in this call today, just as a bit of a change, to see whether it works or not. We had a few people complaining in previous webinars that the noise from the chat and the chat coming up on screen was a bit distracting to the content that was being gone through. And this is a complex topic, so we've actually disabled it. But any questions, please do pop them on the Q&A, or if you've got any problems, please email marketing@vivid.care. I think that's everything from me. So over to Joe. Joe's been with us on a number of webinars now. She's a posture specialist, she's an OT, and she's very experienced, over 33 years. I'm waiting for that to go up to 34 actually, because we've been doing this for a little while now. Maybe we need to update our slides. But she currently works in NHS wheelchair services as a clinical team leader. So she's still got a lot of hands-on experience. Actually, I noticed now it says 34 plus years as an OT on the slide. So yeah, we need to get that updated further up the slide there. But yeah, she's been involved in wheelchair services, but in a lot of other sectors as well, including the private sector. So without further ado, I'll pass you over to Joe. Thank you for joining us, Joe.
Thank you. And thanks for the introduction. As always, it's a pleasure to work with you as a partner. So just to be clear, I also work independently, so I have no connection to Vivid Care. So today I'm working as an independent practitioner. So I'm not working for Vivid Care. Okay, so I hope today will be useful. Whatever your experience is with MND, I think there's always something new to gain from taking the time for yourself to invest in your own CPD, and just to take that time to think, oh, did I realise that? Is that how I practice? Could I do it slightly differently? Or just to have a coffee and listen and invest in your own CPD. So thank you. So there's quite a lot of content to go through, and some of it will be a little repeating on some slides, so I'll whiz through some and take more time on others. So here's the agenda for today. As per the sign up to the webinar, we like to clearly outline what you're signing up for. So we want you to all have a better understanding of MND and why it matters for our decisions making with seating, the clinical impact of MND on head, posture, breathing, swallowing, how to conduct a thorough seating assessment for MND, how it affects pressure care, the appropriate use of tilting space and other seating accessories, how to anticipate and plan in the role of the OT working with MND clients and as part of the multidisciplinary team, and how quality of life is impacted if the outcomes for seating aren't correct, and how we make best clinical judgments when making seating recommendations for clients with MND. Okay. So this is taken from the MND Association. You can find this on their website, but just to recap again, and some people don't know where you are in your career path, or you may not be a qualified clinician, you may be more of a support role. So that's fantastic if you've joined us today as well. Highly valuable for you to join us also. But motor neuron disease is an umbrella term for a group of neurodegenerative conditions that progressively destroy the nerve cells controlling voluntary muscle movement. So in other countries, it's primarily referred to as ALS. Definitely in America, they only really use the term ALS, but ALS is one of the forms of MND. So we tend to say MND, but within that MND categorization, there are different versions, different forms, different presentations of MND. So ALS is the most common form and the most complex form of motor neuron. So it affects upper and lower motor neurons. So MND is all about the motor neurons. So upper and lower motor neurons are affected with ALS, and the ALS is the one that we see in the news. We see sadly that more and more high caliber celebrities are coming out and being diagnosed with MND, and that's the ALS that they're referring to. So Rob Burrows, that was ALS. The next version, bulbar onset MND, so early impact on speech, swallowing, and rapidly affects respiratory function. PLS, primary lateral sclerosis, affects the upper motor neuron only and has much slower progression. So I've seen people in the wheelchair service that have had PLS for 10, 15 years. Of course, it affects their life, but not in the same way as the rapid onset and the rapid deterioration of ALS. And then PMA, progressive muscular atrophy, is the lower motor neuron. And this, you'll see weakness and wasting without any spasticity. So you won't see any high tone, you'll see the very low tone and the weakness. So each presentation creates different postural and functional challenges. So it's just good to realise that MND is an umbrella term. Okay, next. So why MND presentation matters when we're looking at seating? Well, why does any diagnosis matter? And I think what we really need to keep in mind here, as whatever our role is, whether we're a therapist, a support worker, maybe a family member, there isn't a single seating solution for MND. You have to look at the clinical. Get my words together in a bit. You have to look at the clinical presentation to determine the seating outcomes needed. So use your clinical problem-solving skills to break down, what do I need to do for this client? So sometimes if you're a less experienced clinician, you can be very frightened when you say, goodness, I've got to go and assess somebody with MND later. So that whole MND label diagnosis can be very off-putting, very, very frightening. But just keep in mind that you just have to look at what their clinical presentation is, but be mindful that the progression can be very quick. So you have to do a lot more future planning and using your clinical reasoning skills for what I see today isn't what I may see in 3 months. So going down the different variants. So limb onset MND often presents with weakness in the arms or legs first. So, and it will sadly be these individuals that will say, I've waited a while for a diagnosis, I've been misdiagnosed. It can often be confused with MS, and it can often be confused with a form of arthritis because the weakness and how the limbs aren't operating how they used to, so their functional ability will sometimes be misdiagnosed as MND. So with the limb onset MND, it's really crucial in our assessments that we're having a firm focus on transfers and the correct height equipment for transfers, because the weakness in the legs and the arms will impact that safe transfer, and be mindful of early pressure care as well on how their transfer method is. They could be landing heavily, they could be sliding, shearing, or all that. So looking at the bulbar onset MND, speech and swallowing are very in the forefront of what is affected clinically. So the head neck position in the chair is critical from the very start, and the risks of aspiration, swallow, are very high on the priority for your clinical reasoning. So early involvement and joint working with speech and language colleagues and nursing colleagues is really important. So respiratory onset MND, being mindful of the trunk position for optimum lung function, optimum respiration, is a key priority. So what is the position of the trunk? What is the position of the head? How does the head alignment affect the trunk? So even small degrees of forward flexion in the head significantly reduces breathing capacity and oxygen saturation. So key principles are seating needs will change rapidly. So again, I said at the start of this slide, you need to think ahead, you need to have your crystal ball, you need to look ahead and make sure that your decisions are future-proofed with that individual you're working with. Okay. So 3 stages of MND and what changes for seating. So the early stage, you'll see the localized weakness, that the individual may still be ambulant around their property. They may need to be able to walk across the room and take a little rest, but family members, spouse, daughter, son, will start to notice quite early on foot drop, weakness in grip, some mild speech changes, and the person themselves will often say, this hand just isn't doing what it used to do. It just, and they'll often show you their hand and say, I can't do that anymore. So they'll be noticing the changes. The middle stage, so the weakness will start to increase and the mobility will start to reduce. So the person will say, I used, last month I could walk across this room. Now I can just do a stand transfer from chair to chair. So the limbs will become weaker. You can often see that the limbs are becoming thinner and they'll report that to themselves. Look at my arm, look how thin my arm is. I'm like, I've just got nothing on me. You can see changes in tone, and the head and neck involvement becomes to be more apparent. So this is where we start to need to think about, right, the seating needs have definitely increased. So we need to make sure that we have tilting space as an essential component of seating, posture control, pressure care, and then we need to gently start the introduction and the discussion around, you may need some accessories soon to be added. You need to be very proactive in leading this conversation in a gentle, compassionate way. And then the later stage, you'll see increasing paralysis and respiratory decline. Majority of daily care activities will need assistance. They may need NIV, oxygen. They're wearing a mask at parts of the day, wearing a mask through the night to assist with their oxygen management, saturation for optimum lung functioning. And you'll often see that their capacity to stay awake throughout the day has changed. They'll be drowsy, they'll be needing to rest. That's why the importance of a good supportive care chair with the correct functions will help them rest during the day without having to go back to bed. So keep comfort always as your primary goal, because if they're uncomfortable, their quality of life will be severely compromised. and we need to include the carers at every step with the decision making as well, because they'll be key to making the seating be as effective and efficient as possible by understanding the functions of the seating. A lot of this information, the sources from NHS Inform. Okay. So timing with the disease progression. This awful condition, especially ALS, can rapidly change. It can change in a month. I've seen this. So there's rarely a week goes by in my working life within my NHS role where I don't see somebody with MND. So it can be the early onset, or it can be where somebody's in the later stages, and we will be very involved with this individual. So why early referral and proactive prescription matters, because the earlier services know about the individual and the diagnosis has landed with that individual and that family, the earlier services can support and react. Sadly, within the statutory system, nobody in those systems want any delays, but sadly there are often delays with equipment delivery times. I know that every individual in that service never wants those delays, but sometimes they're outside of their control, which can mean the individual has already deteriorated by the time the chair arrives. So this is very frustrating for that individual who's waiting for the equipment, for the family member who's waiting for it. So future plan, think, oh, I don't think they need tilt. They're doing really well. When I last saw them, they will need tilt. So by having to change equipment is very upsetting and frustrating for everybody involved. So just future plan. Make sure the measurements are accurate when you take them, but be mindful that those measurements can change, because weight loss, dramatic weight loss can be evident, and difference in presentation of postural ability to sit can be different. I'll go into that more later. So make sure the equipment you're choosing is adjustable. Make sure it's easy to adjust. It's not a massive upheaval for that individual to have that equipment adjusted, because then that could easily put them off using it. Oh, I can't be bothered with all this. Just leave it how it is. I haven't got time for this today. I haven't got the energy. So make it as seamless as possible. And just really be just as empathetic as you can and guide them through that. It's not going to be a hassle. We've chosen a chair that's really easy to adjust. It can meet your changing needs, those sort of conversations. And look at the NICE guidelines on supporting advanced care planning from point of diagnosis. Okay. So we can't ever talk about MND, in particular ALS, without talking about head and neck weakness in seating. If somebody gave me a quick fire question, describe the challenges of MND, it would be head support. Always, always head support. So neck muscle weakness is often the most clinically significant seating challenge in MND, in particular ALS. So muscles supporting the head can weaken early, causing the head to drop forward to fall, or to fall to one side. So this is, sorry, a soapbox moment. Vivid Care know I have them. So when you're talking about complex conditions, please use the term head support, not headrest. A headrest is something in the car, or it's on a simple sofa, like one behind me, that just supports your head when you're going back. And that is fine for a lot of individuals, but a head support just gives the importance to that role that we have within our seating assessment to provide the correct head support. So without the correct head support, you often fail with your seating outcomes. So it's just a pet hate of mine, I'm afraid. So clinical consequences of unsupported head position, pain and discomfort in the neck, shoulders and upper back, which again could put the individual off seating. They could say, it's just too painful, I need to go back to bed. Difficulty maintaining eye contact, facial expressions, social participation. So we know with communication, it's not just verbal communication, it's also how we react, how we smile, how we frown, how we look, all of those things. That's why I'm pulling funny faces. If somebody doesn't have good head positioning, you can't read their body language, and communication is way more than verbal communication. So for that individual to have a well-supported head can make the difference between their family members. Oh, I know what they mean. They're not happy with that because I can read it on their face. Increased risk of aspiration. So the head forward position, which we often see, this very heavy floppy head, is huge risk for even swallowing their own secretions. So work closely with your speech and language colleagues and really make sure you're working as your best MDT that you've ever done with these clients. So what the chair can and cannot do. So head support and neck supports can provide passive support, but setting up the chair correctly with the correct angles, with the correct accessories, reduce the demand that's put on the head and neck. So it isn't just the job of the head support, it is the whole setup of the chair. And that's why the fine tuning, the bespoke accessories, the expert assessment is so crucial. Okay. So breathing and swallowing, we know that are to have optimum oxygen saturation, to have good lung function, we need to have a good upright posture. So we know that if somebody is sitting with a kyphotic posture, flexed forward, head down, so the upper back in kyphosis, the cervical spine is flexed forward, that is really compromising the lung capacity. Everything is being squeezed inside and we're not accessing our full potential with breathing. So we need to always think about having a correct head position for breathing, swallowing, and eating. So posterior pelvic tilt and combined with a kyphotic trunk position will compress the diaphragm, as I just said. So just a reminder what posterior pelvic tilt is. Here's our friend the pelvis. That's side on, upright, neutral. Posterior tilt is when it's going back. So we're rolling back, that's posterior pelvic tilt, and that usually goes hand in hand with kyphosis, which is the typical presentation with MND. So we need to support the pelvis in a good upright position, which will help support the spine, which will help align the head. So there's always a risk of dysphagia and aspiration. So we need to have our head in as neutral position as possible and a slight chin tuck position, not this. So we need to, again, if this isn't your area of expertise, talk to the people, work with the people who are expert in this. Never be afraid to say, I need some help with this. I need input from a speech and language therapist or a specialist neuro team, special neuro nurse. Okay. I think sometimes we're afraid to ask for help and afraid to admit that we're not an expert in that. We can't be an expert on everything. Asking for help from a colleague and working in a collaborative way is sometimes the best thing you can do in your role. So pressure care principles specific to MND. Pressure care is always at the forefront of our problem-solving box when we're looking at providing the correct seating. But with MND, this can be particularly pertinent because of the rapid weight loss, often poor nutrition, and poor positioning from their postural presentation. So using tilt in space isn't on a wish list, it's essential. So we want to realign, offload by using tilt in a positive way. So we want to spread the load, and we want to redistribute pressure without always having to transfer out of the chair into bed because the individual isn't comfortable because they haven't got tilt. So seat cushion selection is crucial and it must match the the individual's level of skin risk. So a flat foam cushion is rarely going to be suitable for this client group, or many client groups actually, because our bottoms, our pelvis shape isn't flat. We need contours, and we need foam that allows immersion, and we need to select higher risk solutions involving gel and air. So as we look at the pelvis here, we've got the ITs, ischial tuberosities. We need them to be able to sink into a material. If it's a firm, solid piece of foam, nothing's sinking anywhere. We've got peak pressures here and peak pressures on the coccyx and sacrum. So put on a cushion, select a cushion that will cope with the changing pressure risk of that individual who may be very, very thin, have lost a lot of weight, their skin integrity will be severely compromised, and they've got very little flesh, fat, muscle left to protect them. So you need to provide the correct cushion for that. What I'm always mindful of with cushion selection is the maintenance of the cushion. So you can get very high-tech air solutions, but can the family cope with that? So if I'm introducing air, I would use a lower risk solution, lower risk for carers, not lower risk for protection. So I might use an air cushion that doesn't need to be changed, doesn't need to be pumped, and gives the protection without the hassle of the upkeep for this client group when they've already got so much else they're dealing with. Heel and lower leg pressure require correct foot plate, correct foot support, positioning. So unsupported legs can dramatically affect the positioning of the upper legs and the pelvis and spine. So we know that we need to give the correct support for legs and feet. Okay, next. So conducting the seating assessment, this again, nothing you need to worry about. Oh my goodness, I've got to see somebody today with MND. No, it's, oh my goodness, I've got the privilege to go and do my best assessment for somebody today with MND. So accurate measuring is the simple key skill that all clinicians working with seating should have. There's many times I see poor seating setup, and that's down to poor measurement. And really, I feel there's no excuse for this. So make sure when you're measuring, if you're unsure, you have a colleague there to check with you. Make sure you have a firm tape measure to use. And looking at the diagram on this image here, we're looking at seat depth, we're looking at lower leg measurement, seat height, and we're looking that we're doing these correctly. So if possible, when we're starting, we want to start with an upright neutral pelvis, like in that picture. And we want to check if we're measuring within the seat that they're in or within the bed, we need to make the best positioning choices we can. Document all the measurements accurately, say where the measurements were taken. These measurements were taken in their existing chair. These measurements were taken in the wheelchair, etc. Not everybody has a clinical plinth they can use. I understand that. But if the pelvis isn't upright, if we're looking at posterior tilt, we're going to have a longer seat depth than the person actually has. So note that this measurement was taken with the pelvis tilted posteriorly. So the equipment needed, simple as I've said, the list is there. A colleague is always good as well to do you want to check that? Do you want to check that measurement I've just done? Could you write that down? It's two minds are often better than one. Okay. And how seat depth can be impacted with MND. So we'll often see hamstring shortening when mobility has reduced. The person cannot fully extend, straighten their legs. So it may be that we need to have a shorter seat depth than we think. We don't want if you can see in the picture here, somebody sat with a posterior pelvic tilt, that shows that well. It may be that posterior pelvic tilt is actually fixed like that there. We can't correct it. And often with a posterior pelvic tilt, we will have hamstring shortening. So the individual's knees may be limited in their range. So just be mindful that the seat depth isn't too long and cutting into the back of the leg. So as I've said, lack of active pelvic control when the trunk weakens, when the muscles weaken as the condition progresses. You can often see an individual with MND perched on the front of their chair, and that's because they've not got the active control to push back into the chair, and their pelvis is compromised and their hamstrings are compromised. So we need to make sure that we've got the correct seat depth, the correct functions on the chair to aid that. And sometimes somebody will appear that they have pelvic rotation. So as my pelvis again, pelvic rotation is where one side is forward of the other. Is it actually pelvic rotation, or have they landed poorly in the seat because of weakness? Weaker on one side, they've landed. So just check, can we level up their pelvis? Can we get them, and just talk through with the individual and with the carers, the family members, just make sure when you're getting in and out of the chair, however that is, whatever their transfer method is, that we're landing nice and neutral, nice and level, and explain that. Talk it through, because it's common sense to us, but it won't be common sense to them. They may say, oh, I had realised I was sitting a bit, they'll say things like crooked, a bit skew if, and yeah, but I've just shown you can get your pelvis back nice and straight. So encourage all of this good practice. This education is really important for them to understand the importance of good positioning in the chair. Okay. So seat width in MND, as I've said, there can be rapid weight loss sometimes. With other conditions, having a little bit wider seat won't be a big problem, but with MND, we want to make sure that that person feels as secure and supported in the seat as possible. That's why it's good to choose seating, whether it's wheelchair or home chair, that the seat width, obviously, and the seat depth can be easily changed for changing needs. So lateral leaning to the side because of weakness, slumping to the side will be easier in a wider seat. So if we've got a narrower seat with correct setup of arm supports, the correct width, the correct height, seat cushion, the correct width, seat itself with the correct width, it will help that person feel more midline and secure. It will help align the legs. So if there's too much room in the space in the seat, the legs can tend to drift, which could be wind sweeping. It could allow the pelvic to rotate, like we said. So too much room isn't a good thing. So head position will be compromised, spine will be compromised, breathing will be compromised. So weight change is something you need to be very mindful of. I've seen this very quickly change, and that, you think, blimey, those clothes are really hanging off them now, and I can see this seat needs to be adjusted. So make sure you've done your crystal ball and future-proofed your decision making. This needs adjusting. We don't need to change the chair, we just need to adjust it. Okay. Seat height and foot plate, foot support in MND. So things we will see happening with specific lower leg and foot plate considerations. So foot drop when the individual's still mobilizing, you'll see with their walking, you'll see foot drop. Common as lower motor neuron involvement progresses. So in seating, we need to choose an angle adjustable foot support to compensate for good foot positioning and ankle positioning. We don't want to force the foot, we want to support it comfortably. Comfort again. We'll often see leg edema. So the legs can appear heavy. So the lower leg measurements need to be checked and adjusted. We need to check that we've got good support and equal loading behind the legs if edema changes. So again, liaise with nursing colleagues. They can be involved with this. say to the family, have nurses noticed a change in the lower leg presentation? Transfer methods change rapidly. Seat height must be re-evaluated when transfer methods change. So often you'll see at the beginning of the journey that somebody's still, as I said at the start, doing a little bit of walking and a stand transfer. So then seat height is essential. Then when they progress, I'll talk more about transfer methods in a minute. We need to change the equipment based on transfer method. And we need to make sure that the leg rests are articulating as the leg positioning changes. So has the chair got that function on it? Supportive home chair or wheelchair, is that function available? It should be. Okay. Next. So transfer methods, as I was just not wanting to repeat myself. So independent stand transfer may quickly disappear, but they're very positive at the start. Oh, I can still walk, I can still stand transfer. That's great, but the next visit often has changed. They'll progress to an assisted stand, a stand aid. Make sure that the stand aid isn't compromising their seated position. Sometimes I'll see somebody using a stand aid such as this, a Sarah Steady style stand aid, and they're not landing well in the seating. So then there's too much manual handling involved with getting the person back to the back of the seat, because although they can sit supported on this and be moved from chair to chair, moved from bed, they can't get their bottom right back into the seat because they've lost that strength and they haven't got the ability. Saying push your bottom back, they can't. So then it would be time to start looking at, they've moved beyond the ability of their ability isn't good enough anymore for this type. And then you have to start the conversations about hoisting, which is always a difficult conversation, but the benefits of their positioning in their equipment, wheelchair, home chair, will be very much relying on how they land in it. So if you can't position them correctly because they're still insistent on using the stand aid, even though their ability is declined beyond the stand aid, there's going to be compromises on what you can achieve with their seating. So that's a difficult conversation to have. Involve physio, involve nursing, get everybody talking the same talk, telling the same story, reinforcing the benefits. So make sure that we've got adjustable seat height and angle adjustable foot plates. We need to make sure that we can remove and swing away arm supports so that we're not compromising again on positioning because the armrests are in the way. And the use of tilting space, obviously, for carer repositioning and to take away the burden of trying to manually reposition somebody without tilt. Always document the transfer method and what concerns you noted, and feed that back to other members of the MDT. And if you feel this isn't an appropriate form of transfer anymore and it's compromising your seating outcomes, make sure you feed that back to the whole team, because a stronger voice is a multidisciplinary voice. Okay. So I think we've covered most of this really in the previous slide. So it's the importance of the correct seat height and foot positioning for changing needs. Yeah, I've covered that. I always talk ahead of myself, and I've sort of covered this in one of my previous slides. So we'll gleam over that one. Okay, next. And again, armrest and back height in MND, really important. So we need to make sure, as the image shows here, that depending on the transfer method, we can remove swing back armrests, arm supports, that the upper limbs, when they become weaker, that they're at the correct height to support the individual. They can be using the arm supports very much as part of their postural control. They can be using them for postural stability, forearm loading, postural propping. So we don't want the arm supports to be inadequate in adjustment, so you can't height adjust them to the correct height, both in the wheelchair and in the home seating. They may benefit from gutter arms, trough arms to support their arms, to maintain them in a good position. If they've still got good use of one arm, but the other arm is really compromised, it may just need that gutter arm or wider gel arm on the one side. We want to reduce always shoulder pain, neck pain. So arms are often overlooked as a reason for shoulder and neck pain, but it can be something as simple as that. And then coming to the back height in MND, always anticipate, as I've said, the need for appropriate head support. So if you're measuring for home seating, you need to do a measurement for shoulder height, but also to top of head. This is less important in the wheelchair, not less important, but less of a problem, because the head support will be highly adjustable on stems, in height, in angle, in orientation on a stem. So there's a lot of forgiveness with that within the wheelchair. So the back height is important, and then the head support height can be really, really specifically adjusted. So when we're looking at back height and back type in supportive seating, often the cocoon feeling of like a waterfall back support gives more lateral trunk sort of hug than a flat back. You'd never want to be giving a flat back to these individuals. So in a wheelchair, you'd be looking at like a deep contour back, and in a home supportive chair, you'd be looking at very much cocooning the trunk. So that just feels a lot more supportive and natural. Sometimes individual laterals can't be tolerated because very little skin coverage and very thin bodies feel too much pressure from individual lateral supports, whether they enjoy the cocooning of the waterfall type back or the like the Sedeo deep contour type backs in wheelchairs. So just think a bit differently than you would with somebody with a different postural lean without MND. You'd put a lateral on, but often with MND, they just can't tolerate that lateral support. Okay. And tilt in space and recline. So once we've got the correct setup of the chair, we've got the correct measurements, we know we've done all of our clinical reasoning why we need this chair, we know we're going to get it in a timely manner, hopefully, then we need to make sure that the user, the individual and their family understand the correct use of tilt in space and recline. So MND is one of the conditions where I would very much use tilt and recline together because of the difficulty with the kyphosis, the upper back curvature and the poor head positioning, the use of tweaking so we've got the tilt where everything tilts together, and then we've got the recline where just the back angle changes. So often we say, oh, don't use recline, it's not a good function to use. And sometimes you'll see recline locked up on some wheelchairs. But with MND, the use of tilt and recline together is how you'll get the optimum positioning for head and trunk. So it's the fine tuning. So it gives that opportunity for increasing sitting tolerance, for comfort, for optimum head positioning, for breathing, for swallow, using the two functions together. That is a condition where it's absolutely essential to have both, and for the care and family members to understand the difference between the tilt and recline. Sometimes I'm reviewing somebody, could you urgently review them? They're sat so poorly in the wheelchair, we can't work it out. I'll see them and I'll go, you're just using the recline, you're not using the tilt. So go through it again. And they'll go, oh, so silly. Why didn't realise? Because you've got 101 other things that you're dealing with in your everyday life. So just the compassion of explaining it again, of going through it again, of setting them up, tweaking it, makes the biggest difference. Also choosing the correct postural accessories and making sure that they work for that individual. What they can tolerate isn't always the same as what other conditions can tolerate. So head supports, neck support, sometimes a proper orthotic neck collar is the best option for these individuals, head support and a neck collar together. So they have most likely been referred by physio or specialist nurse or OT as well for an orthotic assessment for a specialist collar, because the risks involved with that have to be properly assessed for, and a risk assessment needs to take place. So trunk supports we've discussed. In home seating, it could be side wings. Trunk weakness will progress, but often it is the forward lean that is the complication with MND. Choosing correct pelvic belts, 2 or 4 point, to prevent the sliding forward, and the correct use of the pelvic belt, the correct positioning of it, and upgrading the pressure cushion when needed. Always think that this client group potentially will have the need for a tray for using communication devices. They may have been referred to the specialist communication centre regionally for assessment of communication device, eye gaze technology. So that it's just such a lot of teams involved with this client group. So make sure the equipment you're providing is one that can accommodate those changing needs. Okay. So the OT's role, I appreciate not everybody on the call is an OT. I'm sure there's some other professionals, all are welcome. So as I said, it's a privilege as an OT to work with this client group, and I think you can be the most OT you'll ever be sometimes. So we as a profession are able to prioritize and plan for changing needs. So you need to look forward, so we're not having to address a big problem when it arises because we haven't thought about it at the start. This can cause delays that cause upset and are very distressing for the individual and for the family. And they'll say, why didn't they think of this at the start if they knew this was going to happen? So you don't want to be that person that they're saying that about. So what sort of future planning looks like in good practice? So at the time of diagnosis, make sure all the specialist teams are involved. Begin assessment, establish your baseline, and start the conversations about the likely equipment pathway that will be needed. They're difficult conversations to have when you're looking at somebody in a house with no equipment, and then in a few months it potentially will be a house with a lot of equipment. But the longer you put off that conversation, the crueler that is, really. When first deterioration is noted, you need to guide the person through the next stage and not just always, again, think of the current stage. As we've said right from the start, choose highly adaptable seating systems that will adapt easily with the person without huge disturbances in their life that become frustrating. And comfort must always be at the forefront of all discussions. If the person isn't comfortable in that seating, they're not going to want to use it, and then it's just going to sit in the corner like a clothes store. So the goal is not just the right chair now, it's the right framework for the whole journey. So that's very much the role that the OT will navigate with the individual and their family, and form quite a close pathway for that individual. Okay. Next. So seating decisions for people with MND rarely sit in isolation. So who else do we need to involve? So very much at the top of the list, the wheelchair service team. They should have a very rapid referral process and response process for this individual. They should be able to fast track that individual so that a home environment check takes part, and they can quickly get involved, even if it's initially to provide a more basic manual chair, but explain to the individual and the family that this is a starting point and we have a pathway, and we can then give you the next equipment very quickly. Most wheelchair services will have this in place. Powered mobility is a tricky one because families don't want it too soon, and wheelchair services won't give one if it's just going to sit in the garage. It's not in their criteria. So it will be one that's conversation will happen, but it won't necessarily happen on the first visit. Speech and language therapists, as I've said throughout, are a key team. Lost my words. Key team with this client group, and their roles will be highly important with managing the risks of all of the swallow and feeding, so that they'll be very involved. The respiratory ventilation team, again, will be involved, and the specialist palliative care team. So it will be an individual with a big multidisciplinary team around them, and seating will be at the forefront of the goals, because that individual isn't going to want to just be lying in bed. They want to be sitting out. They want to be involved as life as much as possible, and they want to be comfortable and well supported, and sitting in their living room. So sitting in the conservatory, make sure it's a chair that's mobile, that's easy to move around, because these are the things that make the biggest difference to these clients facing this very traumatic diagnosis. Okay. And as Tristan said right at the start, and we're definitely singing from the same hymn sheet here, comfort is always the goal, not an afterthought. That should be for every individual, but particularly with this client group. So what does comfort-centered seating achieve in MND? If somebody's in pain, discomfort, and they have to sit in a poor posture, they won't want to sit. They just won't see the benefit in sitting, or they'll continue to sit on their sofa in a poor position, because their sofa in a poor position will be more comfortable than a poorly prescribed seat. I see people sat on their sofas with loads of cushions around them, and then people trying to pull them off the sofa. And I just think this is a sorry state. Enable the person to remain in the room, be engaged, be part of the family activity, with the correct seat. You don't want them having to be in their bedroom. You don't want everyone coming to visit. You're poorly yourself. You want to try and drag yourself out of bed and get up. You don't want people coming to see you in the bedroom. It's your private space. It's very much invasion of your privacy. So have seating that can blend in, be part of the family room. Correct seating, as we've said, will help facilitate and support the safer swallowing and breathing. We can do that by providing good head positioning, neutral as possible, good trunk alignment, and thereby reducing the risks of aspiration at meal times. Just simply having a cup of tea in a poor position, that's a risk in itself. Always thinking about preservation of skin integrity. We can't do that in a poorly supported body. We can't do that in a poorly fitting chair. If somebody with motor neurone develops pressure injuries, pressure ulcers, that is very, very, very difficult for them to move beyond, and they'll often end up back on bed rest, which again is taking away crucial time from their quality of life. So we need to make sure that we're positioning them in a way to protect their body shape, protect their skin, give the correct cushion, the correct size seat. And giving the person the chance to choose their adjustments. I'd like to be tilted. I'd like my head to be a bit more upright. So having equipment that is adaptable, fine-tunable, gives them the control to say, yeah, just a bit more, no, back there where you had it. So easy to adjust equipment that isn't a faff, where the person doesn't feel they're burdened by being asked to, could you just move me like 1 degree, that sort of thing. So document comfort alongside clinical measurements in your assessment. It deserves to be documented well. The person could not have this chair prescribed. They were just not comfortable in it. I've had to make a change in equipment because they just couldn't tolerate the chair that they previously had. Use those terms because they are important. Okay. Next. So key takeaways. There's been a lot of information. Hopefully some of it has been a lot of it has been stuff that you knew, some of it have been stuff that you may have not thought about. But here's some of the key takeaways for me when I'm thinking about an MND client and the assessment that I've been involved with. So MND presentation type determines seating priorities. So don't think, oh, that person's got MND, that chair will work for them, because everybody within their diagnosis, within the type, can vary in how their condition progresses. So don't just think of the diagnosis. Think, like I said at the start, what am I looking at? What are the problems? What can I change? What can I support? Early referral and prescribing is essential, as this equipment lead times can sometimes be frustrating, and we need to make sure we've done everything to avoid that. We need to be as future planned as possible. Head and neck position is directly linked to breathing. Hopefully we all understand that anyway. And getting everything correct within the seating, the correct pelvis positioning, the correct seat width, the correct back height, the correct contours in the cushion will make the difference for good head positioning. Accurate measurements that seating that can easily be changed. These are all important. If you're not sure about your measuring, ask a colleague to double check it for you. Try not to measure when the pelvis is in posterior tilt, when it's rolled back, because that will give you a false long seat depth. If somebody is, you've done your measurements and the measurement looks wrong, just check it again. And there's no shame in saying, oh, goodness knows what I was doing there. That's 3 inches too long. Tilt in space is clinical necessity in MND, not a comfort upgrade. So it's an essential. And document everything, justify everything, share the information with the whole MDT team, make sure everyone is on the same page and your priorities are heard and known. Make sure you argue for that, fight for that individual. Whatever the funding situation is, make sure you fight for that individual. And comfort is a very important clinical outcome. In the later stages of MND, it has to be one of the primary goals. And in good seating, comfort should never be a problem. So they would be my key takeaways in every seating assessment for a client with MND. Okay, I think I've said quite enough.
Thank you, Jo. An awful lot to cover there.
Yes.
There's loads of information that you've gone through, so thank you very much for that. And we will be sharing the slides. So now I'm going to move down to our video assessment room and go through some of the try and bring some of what Jo said to life by showing you on chairs and going through some of the features we've talked about in a live demonstration. And then following that, we'll have a Q&A section with Jo to go through any questions that you might have. Now, at the moment, we've only got one question and one comment on the chat, on the Q&A section. So please do add them there. So just at the top of your screen, it will say Q&A. If you click on that, there's a space to add questions. So we'll come back to those. So just bear with me one moment. I'll move to the video room and we'll go through some of the features and try and bring those to life. Right, hopefully everyone can hear me there. If we can just have a thumbs up from Joe. Yep, good. We're live, we're online. Apologies for the delay there. So I'm just going to go through some of the chairs in our Lento chair range, which is our flagship range of chairs. I've just got 3 specific ones to show you here. There's a few others in the Lento range. But one of the things I'd say from the outset here is we've heard from Joe about how important it is for MND patients, MND, those with MND, to have adjustable seating. So something that can change over time, something that you can adjust in size. And that's one key thing that we've implemented in our Lento range. So every one of the chairs in the Lento range has got easy tool-free adjustment in terms of seat width, seat depth and seat height, and even armrest height and back too. So you can very much tweak and change the chair as needed. So for instance, with your seat width, as the M&D progresses, Joe spoke about the seat width might need to be reduced as they lose weight. So we've got adjustment on the seat width, very quick and easy to do, and you can make that change in someone's home really quickly. So that's key. The other important thing that we spoke about was tilt in space. And again, as standard, all the Lento chairs have the tilt in space action. So what does that, I'll demonstrate on here, what's that actually look like? I'm sure many of you will have come across tilt in space before, but essentially what you're doing is you're rocking the whole chair back, the back and the seat go back together. So you're going like this, and that's got a number of benefits. Obviously, it stops you sliding down the chair. It brings your head back and makes sure that you're not falling forwards. There's the pressure implications as well, because you're spreading pressure rather than just through your buttocks and your thighs. You're spreading it across a wider surface area as well, so reducing peak pressure, improving comfort, but also with tilt in space, they can still see very much around the room. You're not tilting them back and they're not lying there and looking at the ceiling, so great for kind of interaction as well. So loads more benefits to tilt in space, but as Joe said, that is a really key thing to make sure that you've got on your chair. Now, we've spoken a lot about transfers and how when you're specifying a chair for an individual with MND, you've got to remember that their transfer methods might change over time. And there's obviously loads of different types of transfer methods. So you can go right from standing through to using a device like this kind of thing, so like a Sarah Steady type device. There's then even things like side transfers, and then right through to hoisting, fully hoisting. So ideally, you want to make sure that you've got a chair that will progress with it. Will follow the line of progression of MND. So one I'd particularly highlight here is what we call the Lento mobile chair. And the Lento mobile has been a really useful, flexible type chair, because it is a rise recline chair. So you've got the riser action, and you can change your angle of lift as well, so you can get more of a kind of flat lift, if you like, which sometimes can be useful. So it's a rise recliner chair, but it's got wheels as well and a push handle on the back, and you can hoist from it, and it's Sarah Steady compatible, and they quickly slide out for side transfers as well with a banana board. So you can essentially use any type of transfer method with one chair. And that's something that we've found really popular, particularly if you're specifying for a client with MD in their early stages, where they're still standing, they're still able to mobilize themselves, but you know that's going to progress. So a very flexible chair, that's the Lento Mobile, and you can see more on the website at www.vivid.care. So then as we move along, I've kind of arranged these in order. So this is the rise recline that's across with a care chair, and then you move on to a full care chair. So a care chair is just designed really for those that are hoisted, and you get a lot of support. You've obviously got the large casters, and then you've got your foot plate on this as well. And we've spoken about foot drop, etc. We've got an angle adjustable foot plate on here, and we can also attach accessories such as ankle huggers and other types of postural supports, or even on the leg sections here, we can add larger leg laterals to keep the legs in a good position. So this is kind of what's different with a care chair. It's on wheels, your legs are off, your feet are off the ground, and it's all about kind of giving that support, making it easy to hoist, and obviously you've got your tilting space as well. Now this is a manual version, but you can get electric as well with a handset for someone to be able to adjust their position themselves. So that's quite an important consideration to you know, do they want that independence? Have they got the ability to be able to adjust their own position throughout the day? And then on this section here, further along, this is the Lento Cove care chair. So exactly the same base as the Lento care chair, but as you'll see, we've got a completely different backrest here. And there's actually, believe it or not, we've done the maths, 2 quadrillion configurations you can actually make on this backrest. So where you've got a very complex postural case, or you need a lot of head support or a lot of trunk support, which often you do with MND, you've got all that adjustment. So each one of these arm sections, on each side they've got 2 pivot points, and so you can really kind of immerse the person. You can bring the soft cushioning to them to make sure you follow their body shape, or try to correct it, give them the support in the right areas. We've also got adjustment side to side on each one of these arms. So if you've got a scoliosis, you can accommodate that. And then you've got adjustment up and down, and also the angle this way as well. So loads of different adjustments, back height adjustment. And I think one of the key things about this is that each one of these cushions, if you like, you'll notice quite a few of this type of chair on the market are more of a kind of solid foam sort of cushioning, whereas we've used the soft Dacron, kind of almost what you'd see in a pillow. We've used that, so you get the support of the metalwork behind it, but you get the softness as well. And again, that goes back to our comfort point. If someone's sat for a long period of time throughout the day, being able to give them that soft support is important. This, in addition to this type of backrest, if you do have a chair more like these types of chairs, obviously as standard with the Lento range, you get the soft cushioning lateral supports here to give a bit of a prompt there. But if you need to take it the next stage, and you don't want to kind of go on to a full chair like this. There are some brilliant accessories which I've just got to this side. So the first one is, I actually liked that Joe earlier used the word cocooning, to try and cocoon someone's back, their shape in the chair, and that's exactly what this is. This is called a cocoon backrest. Again, a very soft backrest, but as you can imagine, when you put it in one of these chairs, these just come off very simply. So seconds just to swap them over. Again, that goes back to that adjustability, having something modular that you can change over time to suit their changing needs. But this just goes in there, and as if you can imagine, the wings and the base of the chair kind of squash this cushion in, and you end up with a lot of support right from the base of your spine right to the head section. And we've got wedges here as well, so you can actually put wedges behind it, so between the cushion and the backrest, and that's a very simple way of getting that soft support in the right place. And you can almost make this kind of adjust to where the support's needed, or maybe put a bit of extra head support in there as well. So I suppose I'm just going through these just to show you what can be done to the chairs over time to make sure that we're following the line of that condition. We're not over prescribing right from the start, but we know we've got a chair that can adjust. And on that note, one other accessory that I wanted to show that we've found works well with MND is, and this can be added again after a chair's been purchased. So a great option for kind of improving what you've already got, and that's this type of head support. So it just fits on a bar to existing fixings at the back here, and it comes over the top of the chair. You've got loads of adjustment on here. You can bring it to exactly the right positioning, and then there's a couple of options for your support as well. So you can bring it quite far round or a bit further back, just to give that head support in the right place. And again, it's adjustable. You can change it, you can move it as someone's position changes over time. Lastly, we spoke about the different types of cushions and the pressure cushions. Again, that might be an area that you might need to reassess and reevaluate and change over time. And each one of these chairs has got completely removable seat cushions, and you can swap them out. So a standard, we use we've got a Levitex cradle cushion. So Joe spoke about some of the shaping on the cushion. So we've got a shaped cushion to follow the body shape, help prevent the sliding forward and give more immersion into the cushion. And we use a specialist foam called Levitex, which there's loads more information on the website about. So that's kind of like that comes as standard with the Lento chair range. But then, as I mentioned, you can take the cushion off very quickly, and we've got other options, gel, right through to air, alternating air. But you can also use third-party cushions as well. So Joe will use a lot of these, I'm sure, the adjustable wheelchair cushions, the contour cushions, deep contour, etc. Some of them are actually, they've got like little modular blocks inside when you take the cushion off, and you can literally almost do like a molded cushion for someone, because you're moving parts around and you're putting leg guides in, gel sacks at the back under the sacrum, etc. So loads you can do with different cushions, different accessories. loads of different options, but I think the key thing, as we've said earlier, is think about the long term. Make sure that you're getting a chair at the beginning of your first chair assessment with someone with MND. You've got to make sure that you're getting something that's an adjustable chair, that's a modular chair, that can be reused, that can be changed, you can alter your seat dimensions, you can alter your accessories, you can alter your cushions, etc. as time goes on, so that you're keeping that person comfortable, so you're keeping them able to live the best life they can. So I think that's everything from me from the demonstration room. Hopefully all that made sense. I'm just gonna whiz back upstairs and we'll go through the Q&A section. Any questions, please do pop them on the Q&A section in Teams now, and we'll go through them in just a moment.
Wait for Tristan to join us again. And we can look at some of the questions and answers.
Thank you for waiting there. So it looks like we've got a few questions. Come in now, so I'll start at the beginning. So a few for me to start with. So some questions here. So, do you offer no obligation assessments nationwide? I'm in the Scottish Highlands. We certainly do. We cover the country, and we're quite lucky actually. We're actually based in Yorkshire, near Leeds, so quite centrally based, and we do cover the whole of the country. So please do give us a call if you've got any particular client in mind, any needs. Is the Lento Mobile available in bariatric sizes? Yes, there's a similar version of the chair. We do mediatric and bariatric, so 40 stone and 50 stone. All of them are adjustable in terms of your seat dimensions, etc. There are a few slight changes to the bariatric version, but we can certainly talk through that. And someone's asked whether the Lento Mobile has tilting space. It certainly does, yes. So you've got a single motor tilting space, but then you've also got the ability to upgrade that to a dual tilting space. You've got the backrest is on like a fixed bar, which you can change your fixed angle, and that comes as standard, or you can just quickly, without tools, change that bar to an additional motor and plug it into the control box, and then you've got a dual motor tilting space. So again, giving you that flexibility as time goes on, if you need some to open out the back angle, or you need that ability to adjust it throughout the day. Sorry, just reading through. What chair will provide rise, but then also be compatible with hoisting? So that's the chair I showed, the Lento Mobile. Certainly happy to talk through in more detail if there's any specific needs there. This is an interesting one. We're being told in my NHS position that postural seating should be up to wheelchair services. and are often getting requests for specialist chairs turned down if the person has a wheelchair. Is there anywhere we can find more evidence for the benefits of specialist seating as a break from wheelchair for comfort? Jo, have you got any thoughts on that one?
I would have a very strong opinion on that in my NHS role, in that we will say the exact same. You need suitable home seating because the wheelchair service is a mobility device. It's not to be sat in for too long a period, and it doesn't take the place of it doesn't one seat will not do everything. So I would kick back with, and I think you'll find every wheelchair service in the country will have a very similar criteria, in that unless somebody has supportive home seating, they won't give, MND is slightly different, but they won't give a wheelchair in place of that because they're not funded for that, they're not commissioned for that. So unless somebody has supportive, appropriate home seating that they're evidencing that they're going into, they will not just be given a tilting space manual or powered chair to do the job of that. But I have heard this a lot around the country, and it's not accurate. It's not right. It's really not right. We don't just have one seat for everything, do we? We have different seats for different things, and you can't achieve the same in both. One's a mobility device and one is supportive home seating. So
yeah, absolutely echo what you say there. Some councils and places have very specific kind of a no seating blanket type rule in place, but in that kind of situation, you generally be looking at kind of self-funding, or we do have a charities list that's downloadable from our website under download section, and often you can find that that some charities will kindly help, but it is a shame, and as Jo said, they are very different function seating. So and I think the other thing I'd say is that we do offer hire of chairs as well, so that is another option. Or if they are funding privately, we do have a finance option as well, so they can pay over time each month. Interesting one here for you, Jo. Do you use head straps? Are neck collars the only option after tilt and recline have been exhausted?
really interesting, and in some instances, anterior head strap will be used. There'll be a risk assessment involved, and certain specialist head supports have the option of a head strap or a chin prompt underneath, none of which can be used in transport. And sometimes I have used those, and it's made a big difference for individuals using eye gaze, etc. But there needs to be a risk assessment involved. With heavy head forward drop, sometimes the band will ride up, and sometimes the chin prompt will migrate a little bit. But it is an option on specialist head supports, but should only be used with the device it's intended, and not putting a homemade thing on, which I have seen as well.
Yeah, I think it's rare to use them, really, isn't it? I can only think of perhaps a couple that we've needed to do that. You can do a lot with tilting space and with good head support, but yeah, that is kind of
it is possible,
last
and
resort.
the anterior head pads that you can get on some of the head supports tend to be more beneficial than the strap. So they need highly specialist clinical team to set them up, in combination with the good positioning behind the head and the neck, and then using some anterior head pads for specific activities to do with communication or feeding.
Another question here. Are all the cushions in the seat of chairs all high risk pressure relief? Good question. And I think what you'll find with most chairs is they start with a medium risk pressure relief. And that tends to be because not everyone needs the level of high pressure relief, and that does add to the price. But I think the important thing is think about the future. If they're going to need high pressure relief in the future, it kind of makes sense to specify that from the get-go, and then just making sure that you can swap cushions out and change them in whatever you choose, just to give you the flexibility, because it might not just be about the pressure side of things. It might be more about giving more support to the legs. So you might want a cushion with leg guides or that kind of thing. I don't know whether you've got any comments on that, Joe.
The other problem with classifying medium high risk, it's if you give somebody something that's classified as high, the manufacturer will have classified it as high risk. But I think the individual clinician will have to do the risk assessment, because high risk doesn't mean you can sit on it all day. And high risk doesn't mean if somebody's been poorly put into the chair that it's going to work. So if you've got gel or air sections at the rear, somebody's been put in poorly with the wrong transfer device, and then they're not even accessing the air or gel, that's not going to work as a high risk cushion. So the individual is high risk. So the cushion setup will only be correct when it's been correctly used. But what I find with classifying medium, high risk, etc., is that people then think it's a license to sit all day. But really, maximum 4 hours sitting, we would always say, when using tilt as well to vary the angle. And after 4 hours sitting, the individual should change position, come out of the chair. But with the high risk badge on things, people think they can sit all day. That's the complication I see a lot.
Yeah, and every case and every individual is different, but also it changes over time. So that's why it's important to do seating reviews. Go back out, check the positioning, check the chair's been used properly, and check what their current state is like. Has the illness progressed? I think the other thing is that the actual pressure care in the seat, in the cushion, is just one of the tools we've got at our disposal. So we've mentioned tilting space a lot. And it's not just about using tilting space, it's about varying that tilt as well, because then
definitely.
you're changing your pressure points throughout the day. So that's really important. And then the other thing, which is, I know you've got some soapbox moments, Joe, but you'll recognise my soapbox moment here of seat sizing. You can have the best pressure care cushion, but if your seat height's too high or your seat depth is too short or too long, etc., if you don't get those measurements right to start with, then you're still building up pressure somewhere, and that can lead to pressure damage. And I think it comes down to even the material on the cushion. So I noticed a useful comment from Baron on the Q&A section. When selecting a cushion, would you agree that the cover materials are at least as important as the cushion core materials when considering effects of shear and microclimate on skin tissue integrity? Well, absolutely. You need something that's breathable. Obviously, sweat or lack of air, and the warmth or even urine, etc., you can build up a microclimate, which then leads to pressure damage and the shear and friction as well. So it's really important to think about the material. I don't know if you've got anything more to say on that, Joe.
Education around that, because the amount of times you've done a very accurate assessment for the correct cushion that's correctly set up, and then you go and do a review and somebody's got a towel on it, and you think, we've gone to the extent of giving you the cushion that's correct, positioning you correctly, reviewing it, setting it up, training everybody involved, and then you've put a towel on it. So you may as well just go back to sitting on more or less a standard cushion. But, oh, well, they're leaking, they're this, they're that. Well, we can't take responsibility for their skin integrity when you're putting a towel on it. Or putting the wrong cover on that cushion so that it doesn't perform correctly because you're not able to immerse into it because the tension from the wrong cover's always been putting on. I've seen yesterday the wrong cover on the wrong cushion, and I think, for goodness sake. So yeah, it's a very, very, very important point, Berend. Yeah.
Thank you. And I think we've actually already gone over time. Sorry, we're not going to be able to cover all the questions today. I'll give you one more, Joe, if that's all right.
Sure.
From your experience, is there any way to expedite wheelchair seating provision for people with MND to maintain functional involvement given the progression of the condition? Thought that was a nice one for you to finish with your role.
I just think having a good line of communication with the wheelchair service, making sure that build those bridges. I think every wheelchair service would want to have good communication open, especially with this client group. They are going to want to be the best for function and quality of life within the remit of their funding. That's the problem. But they will want to give the best equipment for changing needs. So
absolutely,
I don't know whether that answered that, to be honest, but
no, I think it does. You had a slide earlier about the multidisciplinary team, and that's so important, particularly in MND, because it's a complex condition and there's a lot of people involved. You need to know these are the people that you're going to be working with, and you need to be able to have that relationship and talk to them, whether that be the wheelchair services or other teams, physio, etc. So yeah, it's really important, and I think you have answered that. So thank you, and thank you very much, Joe, for all your input on this webinar. A lot of information. We will be sending out the slides and the recordings as mentioned. And if you do want to find out more, said this at the beginning, but there is loads of information on our website, www.vivid.care. There's some really useful ebooks on there. We spoke about the difficulties in getting seating in some of these cases. Well, we've tried to make it easier. We've got a lot of different justification forms and templates and ideas that you can download from there. Prescription forms. There's other training videos and past webinars, etc. And then loads of different articles on there as well. So please do have a look at the website. There's a lot of resources on there. And as mentioned before, if you do have a specific client or situation or even ward in a hospital, etc., that's needing specialist seating and you want some help with that, please do reach out to us. Completely no obligation, and we can do a thorough assessment and even help you with your clinical justifications and reports afterwards too. So contact details on the slide there. And with that, thank you very much again, everyone, for joining us today. Thank you, Joe, and I hope you have a lovely rest of your day. Thank you very much.
Thank you. Thanks, everyone. Bye.